Hope everybody's doing well. It'll be myself and Kirtan who'll be facilitating today. So just like to welcome everybody. I'll go around and have everybody introduce themselves and tell everybody a bit about themselves. You want to?
For them, and we need to discuss it. Please go ahead. Next, Kirtan.
Yes, so good afternoon, friends. Today we are going to discuss an amazing case which Rafa kindly agreed to present to us. And today we kind of have full house. So like we have Anne Mary here, we have Rabi here, we have Reza here, we have Dr. Ravi here. So it's going to be a great session and we are going to learn a lot. And another interesting thing that it's around midnight here. So it's like even half past midnight. So it's definitely going to be an adventure for me, that how I solve the case at 12:30, so that in real life, how I could do that in future, it's going to be great. And as usual, we are looking for 2 discussions. So if you want to discuss, please volunteer in chat. And it's going to be pretty low key. Don't worry at all. We are here to learn. And of course, the focus is going to be on the process of diagnostic reasoning rather than on the diagnosis itself. So please don't hesitate to volunteer if you want to discuss a case. And we already have a case here. So it's going to be great. Now we just need 2 discussions. And now maybe I would like to pass the mic to Gabriel to introduce himself.
Thank you, Gertan. Hi, everyone. My name is Gabriel. I'm quite excited to be here today. I'm a medical student from Lima, Peru, and I'm just so happy to see the incredible Kirtan and Ravi, two master teachers for me. And I know this will be a very exciting case for Rafa, and I'll pop over to Brody.
Hey everyone, Brody here, and I am so glad I'm not doing teaching points today. But I'll be scribing today, and I just finished my 5K, and I'm just fresh to learn some medicine. And I'll popcorn it to Anne Marie, I guess, yeah.
I am in the hospital right now, but also really excited to tune in to hear what's going to be an amazing discussion today. Sorry, I was kind of split between 2 tasks. Anyone else here want to introduce themselves?
I can't help but unmuting out of sheer excitement. Y'all, this is incredible. I'm so glad. For those of you who are joining for the first time, I'll tell you that we don't do this much of a pump up on most VMRs, primarily because a lot of us have probably snoozed the rest of you to sleep, including RLR on Friday with Rez and I. But today's a first. It's a dynamic duo of 2 people who we absolutely adore, Ravi and Kirtan, who are taking this on as a facilitating couple for the first time, and our discussant couple are VMR legends, in my opinion. I just saw, not to take the thunder from Ravi and Kirtan, who will pair up with you, I just saw Jasimran and Shema volunteer to discuss, which is such a delight. So you're all in for a treat. Don't get used to this. This is a special, special occasion, and it really, really is exciting to be here.
I'm going to ask Shema and Jasimran to introduce themselves. Shema, you want to start?
Sure. Yes, my name is Shema. I'm a 4th-year medical student from Germany, and it would be my first time doing a discussion, so I'm very excited.
Good morning. My name is Jasimran Singh. It's good to see Dr. Singh and Kirtan here, facilitating. And Shema, I already knew her, from a lot of tutorials. So it will be a great session, I know.
Awesome. Yeah, I also follow Shema. You've been on some of the VMRs and typing in the chat and reading quite a bit. So I'm pretty excited to hear what you have to say, and probably will feed off some of your teaching points. Should we get started?
Sure. So Rafa, whenever you are ready, take us away. And maybe I can pair up with Shema, and then Dr. Ravi Singh can pair up with Jasimran.
Ravi, could you please make Brody co-host so he can share the screen?
Done.
Okay.
There you go.
Thank you.
Thank you. And I guess this is the screen. And There you go.
Awesome, thank you. So we have a 40-year-old male with night sweats, a 15-pound weight loss. And that's the end of the article.
Kirtan, you want to start with Shema?
Sure. So, Shema, what are your thoughts on having a 40-year-old who is presenting with the weight loss? Like some initial thoughts, problem representation, that kind of thing?
So for weight loss, I would always think of any kind of malignancy. So if you think of unintentional weight loss. So the last time we were discussing what weight loss is significant, and the cutoff that was always mentioned is like more than 10% of the weight. I think within 6 months, if I'm sure. Yeah, so malignancy, but also thinking of any infections like TBC. So we have this typical B symptoms with weight loss and together with fever and night sweats. So infection and malignancy would be my first thoughts.
Yes, I think those are excellent thoughts. And I agree with you that whenever we are dealing with a problem, the infection should be prioritized. And since we are dealing with a problem of 4 months, maybe we are dealing with, kind of subacute to chronic infection. And as you mentioned, that we need HPI to figure out whether we have night sweats, point us towards some malignancy, either hematologics or solid. And then, of course, we also should keep autoimmune disorders at back of our mind, because 40-year-old is a kind of a young gentleman. So in young gentlemen, we can get autoimmune disorder as well. So those are excellent thoughts, Shema. Thanks for sharing. And now, Dr. Singh, what are your thoughts?
I'm wondering if just Imran has any input to this before I share my
Yeah,
thoughts.
sure. So these guys summed it up pretty well. So if a patient is coming to me with the weight loss, first and foremost, my priority, as I did most of my clinical experience in India, are they having proper nutrition? A lot of people come from the rural background, and most of them don't have like appropriate vitamins and the important elements of nutrition on daily basis. So the food insecurity, malnutrition will be the very first component. Then the other things, as she mentioned, okay, it's a middle-aged patient, but still we have a lot of malignancies that present in this age group, and that can cause such unintentional weight loss. And then as they proceed regarding the infection. So it is like that some people, even if they are having proper nutrition, but when they become sick, they tend to weight lose. They just become fatigued. And there are some people that respond to infection more sensitively, and they lose weight much more often as compared to other people. And regarding the appropriate definition of weight loss, yes, you mentioned 10% weight loss of that reference age group in 6 months. But here we don't have 6 months, we have 4 months. So you can use another criteria, 5% weight loss of that age group in 1 month. So that is another criteria if the duration is short. So weight loss regarding the chronic infection, food insecurity or malnutrition, and then comes the other autoimmune or malignant causes.
Oh, that's just pure gold. That was a great insight into that problem. But what my thoughts are, we have two different things going on. We have the night sweats, and then we have this weight loss. Very concerning in a 40-year-old. If you take an elderly patient, many of you have learned on my 9 Ds of weight loss in the elderly. So the 9 Ds are dementia, depression, disease, acute on chronic diseases, dysphagia, dysgeusia, diarrhea, drugs, dentition. I don't anticipate that in somebody that's 40 years of age. And then dysfunction, so functional disability, not being able to get to food. But one of the schemas that Robbie had on the website you can access, where the approach is there inflammation on or inflammation off? So if you're dealing with some condition where there's a non-inflammatory cause, you're looking at probably a functional GI problem, decrease intake, just like Jasimran mentioned. So things like inability to get access to food, food insecurity. If there's a functional GI problem like malabsorption, so SIBO, or you have other things like celiac disease or pancreatitis. But when you get to the bucket, like Shema just mentioned, if inflammation is on, then you're dealing with autoimmune phenomena. Is there cancer involved, or is there an infection that's at play here? When you have this this night sweats that's sort of hanging over this weight loss that's going on, you can't help but just think about, is there a malignancy that's going on? is there an inflammatory process where these bee-like symptoms, these fevers, or these night sweats are happening at the same time? Those are a few thoughts there. Did you have any more input, Kirtan?
Yeah, I think that's excellent. We have set up very perfectly. And now I think Rafa, can you give us HPI so that we can discuss further?
Awesome, incredible thoughts, incredible discussion. So we had this patient, he also presented with ear pain, and he refers multiple episodes of bilateral ear pain over the past 4 months. And he also refers joint pain, intermittent flares of pain in bilateral knees, ankles, and wrists over the past 4 months. And he says that the pain improves with ibuprofen. This patient also has a hoarse voice. And that's the end of the secondary quote.
Sure. So, Shema, what do you think? How should we approach this and integrate that into our previous complaints, that is weight loss and night sweats?
Well, I was thinking of these seronegative spondyloarthritis because we are typically NSAR responsive. So this was my initial thought, also due to the joint pain, but I would also consider any kind of rheumatic diseases. So like these, because due to the joint pain, yeah.
Sure. I agree with you. I mean, whenever we have the joint pain, initially our mind jumps to the autoimmune disorders, and it's actually valid, like when we have multiple joints pain and we have going that for a long time. So we are assured that it's not acute monoarthritis due to some disseminated infections. So that's low on our radar. And I mean, we don't still have, that kind of septic signal, like patient is not unstable, patient doesn't have very high fevers. So we can put that out of our concern, the acute monoarthritis, which is always concerning for sepsis. But now if we take in consideration the bilateral ear pain, then another thing comes to mind, that what are some of the entities which can cause, let's say, chronic otitis media or chronic sinusitis, because sometimes, the sinuses and ears are linked in such an intricate manner that pain or inflammation in one of them can spill to another part. So we have to ask ourselves that if we are dealing with, let's say, autoimmune disorders, then what kind of autoimmune disorders can affect the sinuses and the ears? So initially, what comes to our mind? So as we know, oncovasculitis. So things like granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis, microscopic polyangiitis, things like that tend to affect the ears and sinuses. In fact, like the upper airway involvement is very common in GPA. And the fact that we have hoarse voice also points to that, because sometimes the laryngeal cartilages and the larynx itself can be affected in GPA, and that might, point to the hoarseness. But having said that, we shouldn't, get ahead of ourselves. We have to ask ourselves that what if there is something else? Like, are there some infections which can affect the sinuses as well as the larynx? And yes, I mean, sometimes Vipas disease is there, sometimes leishmaniasis is there. I remember that, I guess, on few months back, the Gabriel presented one case where the patient had leishmaniasis, and that leads to hoarseness of voice. So we should keep all those infections, esoteric infections also in our mind. And then, of course, that some endocrinopathies like hypothyroidism can also cause hoarseness of voice. So we should consider all those things. But given the fact that patient also has arthritis, having the autoimmune phenomenon should be top on our list, and we can get, ESR, CRP, complement levels to make sure that how to approach. And now, just Simran and Dr. Singh, what are your inputs to this?
Dr. Singh, okay, I can go first. So you guys already nailed it. So it's regarding something autoimmune, because this much, if you are trying to link all these things, the sinuses, the joint pain, and the rest of the things, the larynx. So one thing is common, the soft tissue you're talking about, there is the cartilage, fat. So obviously, if soft tissue involvement is there, my first thought will directly go to autoimmune phenomena. And malignancy, malnutrition, that can be the secondary thing, that can be low on the differentials. But what you guys already talked about, granulomatous polyangiitis, microscopic polyangiitis, but for this patient, I would first like to go towards the examination. In rheumatology, all the examination of each individual joint regarding whether joint has any swelling, pus, or any other infection signs. If it is about ear, are they having any ear infection signs? Because these can be separate entities as well. He can be having joint pain and some other bacterial infection of the ear. So definitely examination of each individual joint might be the examination of larynx through indirect laryngoscopy, and the ear examination of utmost priority to look whether there is any localized infection in any of these components. If not, then might be they are linked by common entity, that is soft tissue or cartilage in all these things, which is common, and that can point towards autoimmune.
Yeah, a ton of great thoughts there. It sort of leaves me with less to work with, but it's just amazing. You have all these constellation of signs and symptoms. But I agree, we're kind of where our journey started with the weight loss and the weight loss for about 4 months. So it's a chronic process, and then we'd also then integrate this ear pain, which adds another difficult layer to this. What exactly is this ear pain? I was thinking about, could there be actually something within the ear? We mentioned a bit about infection. So does the patient have some sort of a chronic immunodeficiency, which is causing infections for the past few months? So commonly we may have things like CGD or CVID if patient has other immunodeficient states, or is there an anatomical issue with the ear? I don't hear if there's any problem with the hearing, but just pain. We also have to look at the cartilage on the external part of the ear as well, if there's an involvement, and if you rope that in with the voice issue as well, that the patient has difficulty with speech, or pain with the hoarse voice, or sorry, the hoarse voice. Could there be something going on with the vocal cords, which would point to maybe a neurological process? But could there also be, if you look at the cartilage around, or the anatomy around the pharynx and larynx, there's an awful amount of muscle, nerve, there's also bone, cartilage, which could also be diseased in this process. So maybe something linking between the ear and the vocal cords. If you think about a neurological process, the ear pain could be from facial nerve, could be from trigeminal nerve, could be something to do with the jaw, the masseter muscle, could also be something linking with the vocal cords as well. But in that case, we would have a change in the voice, or even we could have some issues with maybe respiratory disease, dyspnea, or even stridor, or abnormal sound. So we're going to look for possible signal within the physical exam. But there were some good thoughts in the chat regarding cartilaginous diseases. So something that we may also introduce. We go on with the next aliquot.
Sure. Unfortunately, this case, we don't have like past medical history, so I'll go straight forward to the physical exam. On the physical exam, this patient has tenderness to palpation of the sternoclavicular, manubriosternal, and costocrondal joints. And this patient also has erythema on the ears, but it spares the earlobes, but hearing is normal. And the remainder of the physical exam is all unremarkable. And I can show you guys a picture of this patient's ear. And that's the end of the aliquot.
All right, so Shema, now that we have evidence of inflammation of ears in physical examination, how this has changed your problem representation and how you think we should approach this case further?
So as we already mentioned, we were thinking of a cartilage involvement, and as we see that the earlobe is spared, we think of polychondritis.
Sorry, I think you froze there, Shema.
Yeah, Shema, maybe you could, keep your video off if that helps.
Again, I didn't hear it.
Sorry, could you repeat yourself? I think she froze again. Shema, could you repeat your?
Sure, I can repeat it. Okay, my internet is not that stable. So we were thinking about polychondritis because the earlobes are spared. So a disease which involves the cartilage, a systemic disease.
Sure. So I agree with Shema that now since we have, sparing of the earlobes, then we have to ask ourselves that what is actually present in the earlobes. So as we know that in earlobes, the fats are present, right? And if we have inflammation of everything apart from that, then we can be assured of the fact that maybe we are indeed dealing with something which affects the cartilage and not the entire ear. Like if it was indeed some sort of chronic infection, then you would also expect the involvement of earlobes. But since we have sparing of that, now we are definitely moving more towards, leaning more towards the autoimmune phenomenon. And there is another important thing in the physical examination. If you look, then we have the tenderness to palpation of sternoclavicular and manubriosternal joint. Now, whenever we thought about arthritis in autoimmune disorders, what kind of joints we talk about? We talk about the small joints of hands. We talk about the peripheral large joints like knees, ankles. We talk about the vertebral column. But not every time you would see that someone would have involvement of sternoclavicular joint or manubriosternal joint, because those kind of joints are very secluded, and usually the autoimmune disorders don't kind of penetrate there. But relapsing polychondritis is kind of a unique disorder, because it's at the crossroads of autoimmune and autoinflammatory disorders. And in many autoinflammatory disorders, we often see that there is involvement of manubriosternal joint and sternoclavicular joint. For instance, I guess few months back, our dear friend Franco presented a case of SAPHO syndrome, like SAPHO syndrome, which was mimicking the inflammatory bowel disease. So if you combine the inflammatory bowel disease and inflammation of cartilage, and you get the SAPHO syndrome. So I guess relapsing polychondritis is very similar because it is kind of autoinflammatory disorder. So you can get involvement of manubriosternal joints in them. And the biggest concern in our case is to halt the inflammation as soon as possible. Otherwise, you can get deformity in the ears, kind of like cauliflower ear, and which is like very severe thing. So we have to immediately get the serological test done, diagnose it, and immediately begin the treatment. And again, sometimes, the stridor can happen all of a sudden and the tracheal cartilages can collapse. That is also kind of an emergency. So we should check the vitals. We should make sure the patient is oxygenating well, because that could be a really and dire situation. So now, again, Jasimran and Dr. Singh, what are your thoughts regarding this examination?
You guys already it's seeming like you are reached to the edge, because they say in rheumatology, examination is still the main thing that we do. And clearly here you can see that there is tenderness on the palpation of the sternoclavicular joint, costochondral joints, manubriosternal, and we have erythematous air spilling with the earlobes. So as you said, the only portion of the outer ear is the cartilage. So definitely cartilaginous involvement is there. We have the cartilage in larynx. We have the cartilage in joints. So that is one thing that is linking all these things. But as you said, that we need to immediately go for the blood test. First of all, the autoimmune blood test that requires the CBC panel, the ESR, CRP, and whether the hemoglobin is normal or not, all those things. And also X-ray of might be the neck area, the larynx, and the X-ray of the joint, because as it can lead to complication of cauliflower ear, but also this patient later on with more inflammation of the larynx or that area can have trouble breathing or like eating food. So definitely it is an emergent situation. We need to get X-ray done as soon as possible. So cartilage is definitely linking between all these three things. We need to get the markers for autoimmune disease, as I mentioned, and the X-ray. These will be the first point. And I was reading one of the things by Hans. He mentioned autoimmune disease might be due to the Crohn's and ulcerative colitis. So I'm just curious to know if someone can educate us, because this patient had weight loss. So was there something like first this had like Crohn's disease or ulcerative colitis, must be having some diarrhea or those symptoms that led to weight loss, and might have other autoimmune association. We do find autoimmune association with these diseases of GI tract. So that is another thing too. That was a good discussion. So that's all for now.
Wow, incredible sourcing from the crowd, or sourcing from Jasimran and Shema, some incredible thoughts as well, Keerthan. It's just such a pleasure to discuss this with you, and also to see guidance from the crowd. But you're absolutely right, actually, Keerthan, I've never seen this disease entity before, but you just hit the nail on the head with a potential emergency that could be forthcoming, as you said, with the cartilage and the structures within the larynx and pharynx. The patient could be in major danger of compromise of the airway. So it's very important to also anticipate that and to understand that process, and not to, there's the diagnostic process. You may have the luxury of time, but there's also time when you have to stop and also implement emergency measures if the patient is in danger of a potential life-threatening disorder. But in this case, one of the sort of like system one thoughts when thinking about relapsing polychondritis is the saddle nose feature on step one that we always think about. There are a couple of other associations, but that was a really nice description of all the different findings that you have with relapsing polychondritis, and especially the ear. But how do we rope in now the weight loss? I'm having a little difficulty trying to, you're talking about, there's a large amount of inflammation that's actually causing this weight loss, or is there a functional disorder? And Simran just mentioned, Hans put in the chat that there could be some IBD that's associated with this, which I'm not aware of, but maybe we can probe a bit more deeper into that and try and bring it all together and put it under the umbrella of relapsing polychondritis.
Sure, that sounds amazing. Rafa, can you give us the next steps?
Sure. There are two more aliquots. The next aliquot is about the blood work. So this patient has hemoglobin of 11, ESR of 115, CRP 137. The ANA is positive with 1 for 80. Rheumatoid factor is also elevated, and anti-CCP antibody is negative. And this patient's NCA, C3, C4, anti-double-stranded DNA levels are all normal. And the urine analysis is also normal. And that's the end of the aliquot. The next aliquot will review the diagnosis.
Sure. So sounds like we have a lot of data and lot of introspection to do as to how to make sense of these labs. So Shema, can you share your thoughts now how to approach these labs?
So with these labs, we can see that an inflammation is going on. We see that the patient is anemic, and ANAs are positive, and RF is also elevated, but we know it's not very specific. So it can be elevated in several diseases, and it can also be elevated in healthy individuals. And to see that double-stranded DNA is normal, and that complement isn't low, I wouldn't think of something like lupus ongoing. So I would rather think of, so we have something inflammatory going on, but I would give the microphone to you, Kirtan, since you're an expert.
No, not at all. Shema, I mean, we lost you a little bit in the end. So since we are not missing your important clues, can you, kind of again share your thoughts? Maybe this time you can keep your video off so that we can hear you fine.
I was thinking of an inflammatory process due to the elevation of ESR, CRP, and as we know, RF might be elevated, but it's not very specific. We were also thinking of if we think of rheumatoid arthritis or something like this, since anti-CCP is negative, I wouldn't think of it because anti-CCP is specific for rheumatoid arthritis, low, so it's normal. I wouldn't also think of lupus. Yeah, and we can see that the patient is anemic, which is also indicative for an inflammatory process ongoing.
Sure. That's excellent, Shema. Thanks for sharing your thoughts and, kind of laying down the framework as to how to approach this. And I agree with what Dr. Singh and Jasimran discussed in previous aliquot, that often it happens that one autoimmune disease is not existing in alone. I mean, it can exist with other autoimmune disorders. So it's always wise to get serological tests done to make sure we are not missing, kind of overlap of disorders. So now ANA is positive, but I guess as we remember that sometimes ANA titers can be positive even in normal persons. And again, the value of titer is very important. So usually in autoimmune disorders, it's like very, very high, like 1:160, 1:320. In our case, it was just 1:80. So which is sometimes not even considered as positive as per some labs findings. So we have to keep that in mind. And now the RF is elevated. So if we ask ourselves that what is indeed RF? So RF is basically the combination of IgM and IgG, right? So all those processes which can lead to chronic immune activation and production of IgM and IgG can lead to complex formation, and that can lead to RF positive. So for instance, as Kushal and Dr. Singh has mentioned previously numerous times in VMRs, that endocarditis is one of the biggest non-autoimmune causes which can lead to RF positivity. So we have to ask ourselves that how to interpret this RF, right? And then of course there is cryoglobulinemias, right? We ask ourselves that they are also known as poor man's rheumatoid factor, because in mixed cryoglobulinemias, that is type 2 and type A, which is commonly associated with hepatitis C and other autoimmune disorders, you tend to get rheumatoid factor positive. But in this case, it's unlikely because of the fact that usually in cryoglobulinemias, the complement levels are low. So we have to ask ourselves that is this cryoglobulinemia? And sometimes, relapsing polychondritis has indeed been associated with type 3 cryoglobulinemia, but the fact that complement levels are normal kind of goes against that. And now what about ANCA? How to interpret the ANCA serologies? So I guess, Dr. Mithu Maheshwarnathan, who once came on our Soft Society VMRs, so he is amazing in rheumatology and he creates these awesome tutorials. And in one of those tutorials, he mentioned that in ANCA vasculitis, we always have to ask ourselves that what is the sensitivity of ANCA? Like in GPA, the C ANCA is positive in about 90% of the patients, but that is not true for P ANCA. So like P ANCA is usually positive in microscopic polyangiitis and EGPA, but it is only present in around 40 to 50% of patients. So, like half of the patients can have negative ANCA serologies. So we have to ask ourselves that how to interpret them, right? And even in ANCA vasculitis, usually the complement levels are normal, so which is kind of going in our favor. But if we now again move to the physical examination, then we know that usually ear involvement in the form of cartilaginous involvement is not common in ANCA vasculitis. So now we can kind of think that, okay, if it is indeed negative, then it is true negative ANCA and rather than false negative ANCA. So again, all the findings are still pointing to relapsing polychondritis. We still don't have any evidence of chronic infection. But still weight loss is something which is bugging me. And maybe just Imran and Dr. Singh, you can help me that how we can incorporate the weight loss into our schema of things.
I think, Kirtan, it's as you are a vasculitis expert and you mentioned the algorithm of both ANCA and the complements very well. So definitely, if ANA is positive and the RF is elevated, and you explained the molecular level of that RF is actually IgM against IgC. So these two complements are involved. But if I'll be thinking against the rheumatoid, like is it an extra-articular manifestation of rheumatoid arthritis, which is very common, but anti-CCP is negative, which is specific for RF. And then another thing that was mentioned before, SLE. SLE can present in any of the ways. But here we see that complement levels are normal. And Dr. Anne-Marie very well mentioned that the other conditions associated with positive rheumatoid factor are cryoglobulin, endocarditis, and other infection. But with the absence of any fever or any of the heart symptoms, we will be like ruling out endocarditis for now. But the cryoglobulin, the mixed type 2 and type 3 cryoglobulin, that will be presented with the decreased level of complements. But in this patient, we have normal. So we can rule out cryoglobulinemia as of now. Now, the main question comes to that my mind is, if we are ruling out everything, and previously as we thought of whether it could be relapsing polychondritis, is what are the antibodies that are specific against the cartilage? So that will be my question to you and to the whole CP Solvers team here right now, that what are the specific antibodies towards the cartilage that we have to think of and get this patient tested for. And as of the weight loss is concerned, I couldn't think of anything else, but the whole thing that this patient is in chronic inflammatory state. So that chronic inflammation at long level will definitely try to increase your metabolism, that will release some cytokines, and all those speed up metabolism, and your body is under stress. You will lose weight with chronic inflammation because of the cytokines and the increased metabolism of your body. So for now, weight loss will be synchronous to the chronic inflammatory state. But Now I want to know what are the specific antibody against the cartilage, and is there any specific test for relapsing polychondritis, or is it a diagnosis of exclusion? So that will be my question.
Some very deep thoughts about these labs. I'm not sure if these labs really help us or do they hurt us. Are they helping us to augment the diagnosis that we're making here, or does it rule out or maybe limit the diagnosis here? But a lot of you are right on point regarding the amount of inflammation that's happening in this patient with the ear and with larynx involvement, and then the multiple different joints that are involved. The SED rate and the CRP are elevated and may actually reflect that. But actually, Anne-Marie has a few comments, and she has this great schema breaking down what exactly is ESR and CRP. So CRP, usually she had commented, rises first and dissipates pretty quickly. I think in elderly patient, it serves as a better indicator of inflammation. You also have to be careful there. You have to adjust the CRP and ESR per the age as well. But in lupus, if we're trying to rope in other possible simultaneous autoimmune phenomena, the ANA can be, as both Kirtan and mentioned, could be non-specific. However, if we're going to consider rheumatoid arthritis again with this patient, the RF is elevated and anti-CCP is negative, so we could probably discount this diagnosis at this point. Lupus, again, C3, C4 is normal anti-double-stranded DNA. And then the great thought that Keaton had, what could there be GPA but in lupus, I think what does come on board is that the get a normal CRP and elevated SED rate in lupus, if I recall. But both the inflammatory markers are elevated simultaneously, so that also counts against lupus. So I think we return back to our original thought that there's relapsing polychondritis, which is probably the most likely diagnosis at this time. But if there's any other imaging, I don't know, Rafa, is there any more aliquots to add to this case that could help us in knowing that?
And Rafa, I guess before we can move ahead, I mean, we can ask again Shema and Jasiman, like, what's their final thoughts on this? So Shema, now we have all the data that we need to have, and we have so far an amazing discussion from the chat as well as Dr. Singh and Jasiman. So putting all of them together, what do you think should be the final diagnosis? And like, what are some of the tests that you are expecting to seal the diagnosis?
The final tests should be, in my opinion, to determine whether anti-collagen type 2 antibodies are elevated, because we know in cartilage is usually made of collagen type 2. But I think even if anti-collagen type 2 antibodies aren't elevated, we still cannot exclude polychondritis because it's not always elevated. So I would still think of polychondritis, and as we already mentioned, the ANAs are elevated, so we could think of a relapsing polychondritis. This would be my thought.
Sure, I think those are excellent thoughts, and that was really actually my idea to that, have to move forward with this. And I agree with you that even if anti-collagen 2 antibodies are not present, I mean, those are the antigens that we see in RP, but it's not necessary that we would get antibodies against them, right? I mean, there are other components of cartilage. For example, there are metrilin, something a cartilaginous component is there, and sometimes antibodies are detected against metrilin, and you can't always detect them. So it may be possible that antibodies are negative, and it's definitely sometimes a diagnosis of exclusion. So we can keep that in mind. And another interesting thing that I actually didn't mention earlier, but I guess Dr. Singh once mentioned briefly, that if we are talking about autoimmune disorders, and then what are those autoimmune disorders which will present with negative antibodies? Like ANA is not so convincing, complements are normal, NK is also negative. So apart from autoinflammatory disorders like RP, we also have to ask ourselves, could this be sarcoidosis? Now, if we think about it deeply, then sarcoidosis can definitely explain the larynx part, it can explain the trachea part, and it can even explain the sinuses part, but it doesn't very well explain the ear part. because sarcoidosis generally doesn't tend to affect the ear cartilages. So definitely sarcoidosis is not very high on differential, but I just wanted to mention it because we actually missed it earlier on in discussion. So that's one thing. So I agree with you that relapsing polychondritis makes the most sense. And unless there is something else which Rafa has in store for us, I think it has to be relapsing polychondritis. And now, Jasiman, what are your final thoughts?
As I mentioned before as well, like everything you are trying to link to relapsing polychondritis is because of the ear finding. And that again illustrates that how important is examination when a patient with rheumatological symptoms present to the clinic, because your main concern towards polychondritis is due to the ear. And today I learned a very good thing, as Seema mentioned, that type 2 collagen will be the one specific against the relapsing polychondritis, but the absence of that will not rule out relapsing polychondritis. And in the chat, Dr. Williams was mentioning regarding that yes, it is a clinical diagnosis, and we need immediate imaging of the trachea to make sure that it is not very much inflamed, and we start her as soon as possible on the therapy. So yeah, that's all. I believe the importance of examination, the new specific antibodies we learned regarding against the collagen type 2, and the other complications that we have to keep in mind regarding these rheumatological disorders.
Absolutely fantastic. I really appreciate some of the teaching points, especially the type 2 collagen comment there. So definitely something to look up. I'm just going to introduce Dr. Williams. I think Reza knows him. Dr. Williams is my program director at MedStar and is also a gastroenterologist. I'm going to see if he's able to. Oh, there you are, Dr. Williams. Could you comment about this case and the weight loss? What do you think? Do you know of any gastroenterological process that happens with relapsing polychondritis?
Hi, Ravi. Great to see you. And Reza, I certainly remember you from your time in Baltimore. What a treat to be on with you all. I hope to join you many more times. Well, I mean, a chronic inflammatory condition and weight loss, they are not incompatible, are they? It seems sometimes, the simplest explanation is the best, Occam's razor, but also that can be a little dangerous to go down that road, of course.
Thank you, Dr. Williams.
And I just wanted to say a quick interjection. I just want to say hi to Dr. Williams, one of my favorite teaching clinicians. How are you, my friend? Nice to see you.
Very good. Very good. You're in Chicago now, huh?
You can't keep track of where I am. I'm in Los Angeles.
You're where?
In Los Angeles. I went Hollywood.
Oh my God. Why did I think you were at Northwestern?
Because I was for a brief period.
But you're in LA now. Wonderful.
In LA now. And I just want to give a huge shout out to everyone who discussed today. I've learned so much from each of you.
Yeah, I just also want to add that Reza would present at Dr. Williams' Medical Student Conference, ACB conference that happens once a year in Baltimore, Maryland. So we'll definitely be missing Reza at that conference. But yeah, to just sum it all up, I think the crowd is pretty much considering relapsing polychondritis as a cause. And just like Dr. Williams mentioned, if we're trying to explain the weight loss, it's probably due to the huge amount of inflammation that's happening in this person. So I guess we can have the diagnosis, Rafa, if you care to share.
Actually, I'm going to give you one more piece of information. This is a CT neck and thorax. It showed thickening of the anterior and lateral walls, the cartilaginous walls, and of the trachea, but not present in the membranous posterior wall. Does it change your differential?
Shema, do you have something to share about those imaging studies?
Well, it wouldn't change my differentials. So, and I also have to admit, relapsing polychondritis isn't my main topic, but I would still stick to the diagnosis. So yeah, what do you think, Kirtan?
Sure. So actually, I agree with your thoughts that definitely even now the RP is a leading diagnosis because, if you see the way tracheal rings are organized around the trachea, then you would find that it is, very similar to how we talked about the ears, that how, ear lobes were spared. So I guess similar thing also happens because when you see the cartilaginous rings, then they also have, they are, not concentric entirely, like they don't encircle the trachea completely. So usually it happens that when you see the thickening on CT scan, that it would be limited to some parts of trachea, and it again proves that we are primarily dealing with the cartilaginous process and not something which is involving the trachea itself. Like let's say if there was some malignancy or something like that, then it would cause concentric thickening of the trachea and not the fragment and thickening that we are seeing. And if you remember, the cartilage is appears in a C shape. So it means that there is some part of that C shape which won't be affected by this procedure, right? So I think that's what imaging studies are showing to us. And now, Dr. Singh and Jasimran, what are your thoughts on these imaging studies?
I totally agree. I think we should give credit to the anatomy of our trachea that this patient till now didn't have that immediate obstruction to the airway passage because the membranous part is spared. So might be right now. So definitely it's the cartilaginous involvement. So it will be polychondritis.
Yeah, absolutely. I agree with that. I think that imaging definitely augments the diagnosis, and I guess we can be pretty confident in our choice of pathology. Just to add, I just looked up my notes for relapsing polychondritis. So other organ systems that can be involved are the eyes. They can manifest as scleritis and episcleritis. Cardiovascular, we must have a suspicion for possible aortic root dilatation, and the skin actually may manifest with some pathology as well, such as purpura, papules, and nodules. So these are other commonly involved systems that we might be aware of. Rafa?
Yeah, you guys nailed it. Amazing discussion. And thank you everyone who joined us today. So this patient actually was diagnosed with relapsing polychondritis, and just and the diagnosis generally made clinically. There's a criteria called a McAdams criteria, and we have to have 3 of 6 findings to diagnose this disease. Bilateral auricular chondritis, non-erosive inflammatory polyarthritis, nasal chondritis, ocular inflammation, respiratory chondritis, and audiovestibular damage. If in doubt, biopsy of an inflamed area may assist with the diagnosis. So thank you, everyone. Such a pleasure to be here.
Sure. And I guess before I can ask Gabriel to share amazing teaching points, maybe I would like to thank Shema, Jasimran for discussing, to Dr. Singh for facilitating, Rafa for presenting the case, and all the amazing things which were shared in the chat. I mean, they helped us a lot in our discussion, and also to Dr. Williams for sharing their wisdom. It's always nice to have some very experienced person in the chat, right? So thank you for joining us. And last thing I would like to mention that, as you know, Dr. Lisa Sanders is like our favorite doctor, right? I mean, she always has these amazing columns in the New York Times. And if I'm not forgetting, I guess 2 weeks, 2 months back, 2 months back, one case was there. And that was actually the case of relapsing polychondritis. And it was tricky because in that case, patient didn't present with the bilateral auricular inflammation. Now you can imagine that that was the pivot point in our discussion. And if the patient presents with something that is not that, then how are we supposed to go to that diagnosis? And in that case, the patient had actually the involvement of articular cartilage. And in that article, it was beautifully mentioned that how we often link the synovitis to autoimmune disorders. But in relapsing polychondritis, actually synovitis may not be present. It's only the involvement of articular cartilage. So you will have joint-like tenderness, but you may not get erythema and swelling that you usually see with other autoimmune disorders. So it was a humble reminder that how physical examination can shape our diagnosis. So thanks to Jasimran and Dr. Singh for mentioning the importance of physical examination during this discussion. And definitely I learned a lot. And thanks again for this opportunity, friends. And now, Gabriel, maybe you can teach us how to approach this case and summarize it in a very well manner.
Thank you so much, guys. I have learned a lot during this case, and what experience for today's episode. Thank you so much for the opportunity for doing the teaching points. So first, we were approaching the weight loss, and I liked the thought process that Dr. Ravi taught us about dividing this condition into 2 categories, the inflammation on and the inflammation off. So for the inflammation off, we have to think about infectious conditions, malignancy, endocrine, and medications. And so inflammation of, for example, food insecurity, dysphagia, dentition, depression, and dysfunction. So the HPI and the physical exam were very helpful and in terms of collecting clues for the final diagnosis. And all the symptoms and the physical examination findings prioritizes an autoimmune systemic condition. We found chronic joint pain. So we were thinking about autoimmune rheumatic diseases, or if this could be a chronic septic arthritis, which would be less common, and also the chronic otitis media and sinusitis and the upper respiratory involvement. We also were thinking about this could be an autoimmune disorder such as granulomatosis with polyangiitis, and also the hoarse voice. It can be explained by the involvement of the epiglottis and the cartilage in it. So we were thinking about if this could be some endocrine issues such as hypothyroidism, infections such as leishmania, or autoimmune disorders. So then with the physical exam and the labs finding, we found a main cartilage involvement. So one of the main differentials that we were discussing along this episode was relapsive polychondritis, which is a degenerative autoimmune process that affects any cartilage around the body. And I also hyperlinked one live resource for a illness script of this condition. And one important fact of this disease is that 1/3 of the cases manifest a concomitant autoimmune disease. So as Dr. Kirtan was suggesting, that it's very important to also do a complete immune workup. And some differentials that we were discussing were lupus, but usually these conditions that don't manifest with elevation of the CRP, and also sarcoidosis, but this could not explain the cartilage compromise at either. So thank you very much for connecting in, and see you tomorrow.
Bye, take care, friends.